Good morning, good afternoon, good evening, wherever you may be joining us from. Welcome to this fourth session of the training series, the last in the series. As usual, we have the chat open for all of you to introduce yourselves. My name is Victor Ndusi. I'm a consulting research fellow at HEI, and I'm based in Nairobi, Kenya. So feel free to introduce yourself, name, country, institution in the chat. We have the Q&A function as well, open for you to ask questions from our presentations for today. And as usual, we'll have a dedicated session for discussion and questions. So while we begin, I will just want to say a few words about HEI. So we are a nonprofit based in the US, whose mission is to provide impartial science that informs decisions and fosters a healthy environment for all. We do this through three programs at the Institute. We have an energy program, an environment and health program, and a global initiatives program, which is the program which brings you this particular webinar series. So our global initiatives program is active in Africa, in South Asia, and Southeast Europe. We do a lot of in-region activities, mostly focusing on providing high-quality impartial data through, as many of you may have seen, the State of Global Air reports. We also do a lot of scientific capacity building, build capacity or strengthen capacity for conducting relevant air pollution and health research, which is part of why we have this series today. Evidence synthesis, we did do a scoping review of air pollution and health studies in East Africa. We're just beginning one for West Africa this month. Hopefully have a similar report for West Africa published mid next year, June, July, same time next year. In addition to that, we also do promote collaborative networks. In the case of Africa, you may all be aware and hopefully will be joining us at the forum. The Africa Clean Air Network has an annual Clean Air Forum every year. This year we'll be convening in Pretoria, South Africa, and looking forward to seeing some of you at the forum. So this is a bit about what we do in the Global Initiatives Program, specifically for Africa. So today, we are in the fourth session of the series. We've had very interesting discussions and very enlightening discussions. We started with air quality monitoring, looked at the methods and approaches, what tools we use across the continent, local sensors versus regulatory monitoring networks, gaseous pollutants versus particulate matter, and all that. Then we had a session on June 2nd, looking at the approaches and the challenges that we face when we try to sort of do exposure assessment in some of our studies. And then the most recent session, we looked at air pollution epidemiology. What are the methods? Why do we do this? How do we approach it? And also saw a few of the challenges that we face from theoretical and practical point of view. So today's session is meant to is less of a lecture style session. It's more to bring you the practical examples from across the region. We've selected a few speakers that you'll see in the next slide to really give you practical sort of challenges that they face and how they solve these sort of issues in some of the studies that they have and projects that they have been and programs that they have been running in their respective localities. So our session today, as I said, is less of lecture style, more of talks. We'll have 3 talks, and as usual, we'll have our 20 to 25 minute sort of discussion session. So looking forward to seeing your engagements as well as we proceed. So our speakers for today, we have Dr. Sairam Kali from the Kintampo Health Research Center in Ghana, Dr. Karadi Wright from the South Africa Medical Research Institute, Research Council, in South Africa, and Dr. Rebecca Nantanda from Makerere Lung Institute in Uganda. So we'll have 15 minutes presentations from each, really looking at some of the projects that they've worked on and how they have sort of factored in all the things that we've learned in the course of this training series. Well, maybe not all, but some of the things and the challenges and how those have been overcome in the course of these studies. So without further ado, I would like to welcome Dr. Sairam to start us off as I stop sharing my screen.
All right. Yeah. Thank you very much, Victor, and thank you to the Health Effects Institute, the organizers of this series, for inviting me to share some thoughts on designing air pollution epidemiological studies. So I'll start sharing my screen now. Okay.
Yeah, if you could also turn on your camera. Yeah, perfect. Thanks.
Good. So, my name is Sairam Kali. I'm a physician and a research scientist at the Kintampo Health Research Center, where I've been working on the Ghana Randomized Air Pollution and Health Study. So, GRAPS is a long-standing longitudinal cohort. We'll hear more about this in the presentation. So here is the outline of my presentation. We'll start by looking briefly at the research gaps, and then we'll finish off with future directions. So Africa experiences some of the world's highest air pollution exposures, but contributes a disproportionately small share of the global epidemiological evidence base. The principal challenge in African air pollution epidemiology is no longer establishing that air pollution is harmful, but generating locally relevant causal evidence across the exposure to policy continuum, from monitoring and exposure assessment to mechanistic understanding and intervention evaluation. But important gaps exist across this continuum. In exposure assessment, for example, there's over-reliance on modeled data and behavioral proxies for household air pollution, for example, and because of the sparse ground networks as well as limited personal monitoring on the continent. In terms of health outcomes, historically, air pollution epidemiology has focused on mortality and respiratory diseases as outcomes, and also to some extent cardiovascular health. Um, but outcomes such as chronic kidney disease, child growth and neurodevelopmental outcomes, mental health, and life course effects have been less studied. So in studying these outcomes, it is important to account for the contextual factors. So contextual factors such as undernutrition, which is still a significant problem on the continent, high infectious burden, the growing problem of heat and climate stress, as well as urbanization and poor access to healthcare. So all these factors have to be taken into account. And there are also mechanistic gaps. So few studies that have integrated biomarkers and then really attempted to understand susceptibility pathways. And in terms of translation and policy gaps, there are still gaps in that area as well. So now looking back at the evolution of air pollution epidemiology, really in the 1980s and 90s, the focus was on characterizing associations with a focus on mortality and respiratory outcomes using methods such as time series and ecological studies. But fast forward now, the field is shifting from documenting associations towards understanding causal pathways, identifying susceptible populations, and generating evidence that informs interventions and policy. So the central question has now evolved from, does air pollution cause disease, to who is susceptible, through which biological pathways, during which developmental windows, and how can exposure be reduced to improve population health. And the remaining challenges include exposure measurement error, residual confounding, the issue of single versus multi-pollutant mixtures, and then having a life course framework. So I'll talk briefly about the Ghana Randomized Air Pollution and Health Study and how we've attempted to address some of these challenges. So GRAPS is a cluster randomized cook stove intervention trial in which we randomized approximately 1,400 women at about 16 weeks gestation to two cook stove interventions. So the study arm consisted of an LPG cook stove intervention arm, an improved biomass cook stove or control. And then once the women were enrolled, they were followed through pregnancy until their infant was 1 year of age. And during the follow-up period, we conducted personal monitoring, repeated personal monitoring of carbon monoxide and fine particulates. And in the graphs, the primary endpoint for the graphs were birth weight and incident pneumonia. So following conclusion of the graphs, we recruited a subset of approximately 700 mother-child pairs for prospective follow-up, which included 3 to 6 monthly questionnaires on general health and respiratory health, as well as annual anthropometric and blood pressure, resting blood pressure measurements, repeated lung function measurements, and then personal monitoring of PM2.5. And then we also have continuous monitoring of ambient PM2.5 at the study communities and then also at a central location within the study area. So graphs provide a unique platform to integrate rigorous exposure assessment and long-term follow-up with potential omics, multi-omics integration to advance causal environmental health sciences and inform policy on clean cooking as well as air quality in Africa. So in designing an EPI study, the first step is to define the research question, or in this case, the causal question. So a well-defined causal question specifies the population of interest, the exposure or intervention, the comparison condition, the outcome, the follow-up period, and the causal estimate. So the estimate simply is the specific target of statistical analysis. And we have to specify this from the outset, whether we are interested in a total effect, indirect effect, an average treatment effect, or exposure response functions. We'll hear more about this in subsequent slides. So the choice of the question then determines the appropriate study design, the timing and intensity of exposure assessment, the confounders that should be measured, and then the analytical approach. So in graphs, for example, one of the questions that we asked was whether assignment to cleaner cook stove interventions reduces blood pressure in children. So naturally, then this leads to an intention to treat analysis of the cluster randomized trial. But if we were to ask how measured exposures, prenatal exposures, for example, relate or influence child growth, then we would have to do an exposure, observational exposure response analysis with careful control of confounding. Right, so having this conceptual and causal framework really helps to outline the various variables in your study and how they are related. So causal diagrams force researchers to articulate the assumptions that they make about exposures, about outcomes, and about other variables. One such causal diagram is a directed acyclic graph, which is one of the commonest representations of variables in a study. And these help us to identify the adjustment set, because not all variables in a study has to be adjusted for. Not all variables that are associated with the exposure or the outcome should be adjusted for. So there are variables like mediators and colliders. If we are interested in a total effect of the exposure, then one would not adjust for mediators. Mediators are variables that lie on the causal pathway of the association being measured. So, for example, in the case of graphs, if we were interested in understanding the effect of prenatal household air pollution on childhood growth, low birth weight would be considered as a mediator. So another type of variable that has to be carefully considered is colliders. So colliders are variables that can be caused by the exposure and the outcome. And in standard regression methods, colliders shouldn't be adjusted for because then they can introduce bias. Um, so we will see an example of that in the next slide. But another challenge in longitudinal studies is time varying covariates. So these are variables that change over time and may simultaneously act as confounders or as mediators or colliders. So for example, in graphs, if we were interested in knowing the influence of prenatal HAP or household air pollution on blood pressure at, say, age 9, we have to be worried about, or we have to consider body mass index and then postnatal air pollution exposures in the intervening years, right? But these may act as mediators. And so adjusting for them in a standard regression model can bias causal estimates. And there are specific statistical methods to handle these, including marginal structural models, G computation, and structural nested models. So let's look at an example, Doug, from the graphs in which the causal question is prenatal household air pollution associated with child growth? Um, and here we have to consider these other variables, whether they are confounders. We need to classify them as confounders or as mediators or as colliders. So socioeconomic status, for example, would be a confounder because it is associated with both the exposure and the outcome. But if we were interested in the total effect of prenatal air pollution, then we do not have to adjust for birth weight in our regression model, and then also postnatal exposures and clinic attendance for illness, for example, would be something that can be caused by poor growth as well as prenatal air pollution exposure. So that can act as a collider, and we need to use other methods to handle this if we wanted to adjust for it rather than a standard regression model. So coming to exposure assessment, so we've heard a lot about this in the previous presentations in this series. So I'm just going to focus on the timing of exposure assessment or exposure windows, and then the issue of single versus multi-pollutant models. So the health effects of air pollution may depend not only on the magnitude of the exposure, but also on when exposures occur during the life course, and identifying susceptible windows is critical to causal environmental health science. So historically, many studies estimate average exposure effect over broad periods. So for example, average PM 2.5 exposure over pregnancy, on birth weight, or on later childhood blood pressure, or trimester-specific effects. But these questions do not tell us when when the organism is most susceptible to environmental insults. And so using methods that can identify those exposure windows really help us to identify the critical periods of vulnerability. And in speaking about exposure windows, there are models, life course models that have been developed in understanding the timing of exposure and how these relate to vulnerability of effects. And these include critical window model, which basically is that exposure has effect only during specific periods. As outside of those periods, there's little or no effect. Then the sensitive window period, which is similar to the critical window period, just that for this model, exposures have greater impact during the sensitive window compared to other windows. And then there's the accumulation of risk model and the life course pathway. So what methods are best suited for a life course model? So in the graphs, we relied or we used distributed lag models to identify susceptible windows, so to identify exposure windows during which high exposures would be associated with worse health outcomes. So in this case, I use pneumonia and then lung function as examples. So imagine that we want to know whether air pollution during pregnancy affects birth weight. And instead of averaging exposures across pregnancy, we want to know which week of pregnancy matter most. And a distributed lag model helps to answer this question because it estimates separate effects for each week or each month of exposure. So a distributed lag model is like a moving magnifying glass that scans across pregnancy and asks us which specific week is exposure most strongly associated with outcomes. And so in this example for graphs, we used distributed lag model to determine the relevant windows of exposure for severe pneumonia. And we found this to be in late gestation. And then for lung function, we found this to also be in late gestation. So this then begins to help us understand the underlying mechanisms underpinning these epidemiological associations when we use these models. But there are other methods like the Bayesian distributed lag model, which handles correlation in the data between successive windows, as well as longitudinal trajectory approaches. So now shifting our attention to the issue of single pollutant versus multi-pollutant models. So traditional analysis estimates outcomes as a function of a single pollutant, so PM2.5 or carbon monoxide. But in reality, air pollution is a mixture of different pollutants, right? So carbon monoxide to nitric oxide, black carbon, ultrafine particles. And really, air pollution is a mixture of household air pollution and ambient air pollution. So how do we take into account this multi pollutant mixtures? You can't just put all these exposures in a standard regression model because then you're worried about collinearity. So there are methods that have been developed to handle these. So modern mixture methods include quantile regression, BKMR or Bayesian kernel machine regression, and quantile G computation. So these are able to model multiple pollutants. And the emerging frontier is the exposome, so putting together all these exposures, so air pollution, heat stress, noise pollution, diet, psychosocial stress, infectious burden, as well as chemical exposure. So putting all these together, understanding that all these also have impact on air pollution, but how do we model this? Right now, shifting attention to outcome assessment and phenotyping. So modern life course epidemiology increasingly focuses on intermediate phenotypes that lie along the pathway from environmental exposures to clinical disease. The gold standard outcomes are the clinical diseases, right? So cardiovascular disease, chronic lung disease, stroke, and chronic kidney disease. But then we will need to follow up individuals in the setting of a cohort study, like graphs. We will have to follow individuals for decades in order to record our outcomes. So we can study, instead of studying these clinical outcomes, we can study intermediate outcomes that lie on this pathway. And these are closer to exposure, so they give us a better mechanistic understanding. So using these outcomes, we can ask the question, can we detect disease processes decades before clinical disease becomes apparent? And this is particularly relevant in low and middle income countries. where access to healthcare is poor. And if we can identify individuals early before disease processes become manifest, then we can prevent these diseases from manifesting in the first place. So some of these intermediate markers, so for hypertension, include blood pressure, for chronic kidney disease, glomerular filtration rate, so as a key measure of kidney function that can be studied in the context of pollution cohort studies. Albuminuria is another one, presence of albumin in the urine. For COPD, so lung function measures such as the forced expiratory volume in the first second of spirometry maneuver or the forced vital capacity. So for cardiovascular diseases, we can study intermediate outcomes such as arterial stiffness and carotid intima media thickness. And then other outcomes, including insulin resistance or diabetes and growth outcomes as well. So now considering the statistics of it, in the graphs and in most environmental epidemiologic data sets, the data sets are complex. They are rarely simple data sets. So the statistical model must reflect the hierarchical structure of the data rather than treating all observations as independent. So in the graphs, for example, we measured blood pressure in kids who belonged to different community clusters, and kids who belong to the same cluster will be more alike than kids who belong to a different cluster. So we have to take this into account in the analysis. And if you introduce the element of longitudinal data where we had repeated measurements on each participant, then that introduces another layer of complexity. So in this case, we have repeated blood pressure measurements as well as other intermediate phenotypes in kids who are clustered within communities. So the approach to handling this, one approach is to use mixed effects models, and these models explicitly partition the variance into different components. So for the BP example, we would have between community variance, then we would have between child variance, and then within child variance. There are other methods like the generalized estimating equations that aim at estimating population averaged effects while accounting for the correlation among the data, and then marginal structural models. So in the graphs, how did we handle this? For our analysis, we mostly used mixed effects models, and for repeated measures of child growth as well as child BP. And these allow you to introduce random intercepts and random slopes to handle that correlation in the data. So this is the general form of the equation for a mixed effects model. We see the fixed effects component, which is basically the average effects for everyone, across everyone, and then the random effects component, which is at the individual or community level. So it includes terms for the community level as well as at the child level. So each child is allowed to have their own baseline blood pressure. And then the child level random slope takes care of the rate of change of blood pressure over time in this longitudinal type of data. So the next is to talk about the exposure response relationships, because mostly in air pollution epidemiology, we are interested in modeling exposure response relationships. And there are different types of exposure response functions. Generally in epidemiology, we have a linear relationship, we have a plateau effect, a saturation effect, and others. And in air pollution, linear functions are common. Plateau or saturation functions are also common. Log linear or supralinear functions very common. So why this is important is that assuming linearity when the true relationship is nonlinear may underestimate or completely miss important effects. So from the outset, we need to make assumptions, and we need to determine which function to use, but then the statistical model can help us to determine these. So some of the methods that statistically that can help to model non-linear relationships include restricted cubic splines. So these are very common in epidemiology, as well as use of fractional polynomials, and then generalized additive models. So in model selection, one should think about the biological plausibility. So it may not be biologically plausible that an association is linear. So for example, if you wanted to find the effect of prenatal air pollution on
Carly, I'll
growth.
ask you to please wrap up. We are running out of time.
Okay. Yeah, so one has to think about all these factors. And in graphs, so here I give an example of how we approached this in graphs. So in modeling the association between prenatal exposure and child growth, we began by fitting a linear model, and then we assessed departure from linearity, and then we fit a log linear model, and then we used log likelihood ratio test and AICs and BIC to determine the most appropriate functional form. So the key is to choose the simplest model that allows easy interpretability of the data. Another issue to consider in designing studies is the issue of attrition and missing data. So especially in longitudinal studies, you will encounter missing data, and one has to determine the missingness mechanism and then how to handle missing data. So now integrating these intermediate phenotypes that we've talked about um, to understand biological associations, because historically epidemiology has focused almost exclusively on estimating exposure response associations. But if we focus on mechanistic epidemiology, where we integrate molecular markers with intermediate outcomes, then we can begin to identify to ask causal questions. So air pollution doesn't just lead to heart attack, it will proceed through mechanisms. And if in the context, in the setting of a cohort study such as the graphs, there are opportunities to integrate biomarkers to map out these biological associations. So future directions will include leveraging birth cohorts across the continent, including demographic and health surveillance systems. So adding air pollution exposure measures to these surveys, to these cohorts, and then also paying attention to the issue of environmental justice, because exposure varies and people are different in terms of their susceptibility. So identifying susceptible groups, and then future studies attempting or integrating the multi-omics as well as social determinants and co-exposures towards precision environmental health. And here are some references. Thank you.
Thank you for
So,
that,
yeah, Victor, over to you.
Sarah. Yeah, thanks for that. I think you started by defining that, we've moved from the question of whether air pollution is an issue to who does it affect and by how much. And therefore, trying to answer some policy relevant questions. So participants, please do include your questions for Carlos Seyram's presentation in the chat. I see a lot of representation from Ghana already in the chats and the introductions. So do feel free to pop in your questions as we move on to our next presentation from Dr. Karadi Wright from South Africa Medical Research Council. Karadi, the floor is yours.
Thank you very much, Victor, and thank you for having me this afternoon. I'm calling in from South Africa, and I'm going to put my slides onto full screen mode, hopefully sometime soon. Right, is that okay?
Yeah, perfect. We see that. Yeah.
Okay, excellent, great. So we've had quite a theoretical presentation ahead of mine, so I'm going to shift things up and talk to two examples. In fact, they're interconnected. Here in South Africa, where we have used epidemiology to inform policy change, two very specific examples of having done so. And really, hopefully, I can emphasize the importance of the appropriate study designs when one is wanting to make change. So, to start off with, I think we should start with a bit of a story. Um, and I asked HEI if they were recording this, and they said they are. So hopefully I don't get into too much trouble. But fortunately, I'm good friends and colleagues with the South African National Ambient Air Quality Officer. So I don't think this story and me recounting it will come as a surprise. But in 2010, so some 16 years ago, the Department of Forestry, Fisheries and Environment asked the CSIR, Council for Scientific and Industrial Research, where I worked before the Medical Research Council, to undertake a study in the air pollution priority areas of South Africa. So these are areas, they're inland, they're highlighted there on the map, the middle map in green, pink, and blue. And they are areas renowned for having very high air pollution levels. So the Department of Environment solicited particular studies. There were two studies that were solicited. This was one of them where we looked at lagged acute respiratory outcomes among children in I think this was in the Highveld priority area. There's three, the Highveld, the Vaal, and the Waterberg-Bodonala. And we conducted lung function testing. It was a cross-sectional study. We did the work in schools with the collaboration of the Department of Education. And we found, so if you have a look on the map, I hope that map is showing, I don't know if I think it should be showing air pollution in the area that we were most concerned with. And then the chart at the bottom is showing cough. So, and this isn't lung function test results, but in this instance, I'm just showing cough as an illustration. And you can see that there is some indication of a slight increase in cough symptoms reported by these children through the days following, so with a lag of up to 5 days. And this is in an area where many of these pollutants are typically well above the World Health Organization air quality guideline values, as well as above our South African national ambient air quality standards. So we did this piece of work, and the well, let me tell you about the other piece. So the other piece is a similar study, this time again in the air pollution priority area, a different one. And here I'm showing this is lung function among children. The plot is indicating how the indicator here that I'm showing for lung function showed a decline over time. And so essentially, we now had two cross-sectional surveys. They were very expensive. And what happened was the official government reports never saw the light of day. The first report was launched in hard copy at an event in Cape Town, which is a very clean city relative to the three pollution priority areas where we did this work, and it was never released online. And the same for the second report, never released online, and it came out at the time at a very, very critical time, which I'm going to tell you about in a moment. And it's probably the reason why it was never launched. Now, The reason being for the launch of these reports, at least the first one, was given that the Department of Environment did not have the mandate to solicit a health study. That should have been done by the Department of Health. Now, that's a very interesting thought because the Department of Environment has national ambient air quality standards, which are based on health, and they have to be measuring, impact of those standards on health, and yet they can't measure health. Anyway, so that was the reason given for that. Subsequent to these two studies, we did work funded by the Foreign Commonwealth and Development Office of FCDO of the UK, again in the three air pollution priority areas in South Africa. This time we were looking at, in this part of South Africa, it's our coal-powered fire stations homes. We've got dozens of these. We are a coal-based economy. And so we were looking at whether if you live in a district municipality where there is a coal-fired power station, does it affect your health compared to if you live in a district with similar background air pollution levels and so on, and it doesn't have an air coal-fired power station. What are the differences? And overall, we saw that there was a 6% higher chance of dying prematurely from air pollution exposure if you live in a district with a coal-fired power station. So this is now a later study. It's fairly recent in the last 5 years, but again emphasizing that despite the fact that these three air pollution priority areas are places where the air quality monitoring is better maintained and they really are a focus of national government, we are still seeing adverse health risks in these areas. Remember, all of these have been cross-sectional studies. This particular study with the coal-fired power stations used observed data from mortality records and from morbidity records. Now, what this all led to, and the reason why that second report was never released, was because it came at the time of what is now a rather famous case, not only in South Africa, but I think globally, called the deadly air case. And this was where the communities with NGOs took all the evidence that they could find and used that evidence to take the Department of Environment to the Constitutional Court for the breach of the right to an environment that is not harmful to one's health in South Africa, particularly the right to clean air. So we had used all this evidence, and you might want to know how NGOs and communities got the unpublished reports. Well, I'll leave that to your imagination. But they used all of this available evidence to really lobby to emphasize the need for a change in these areas and much more stringent control of air pollution. This court case is ongoing. This is from 2025, but it's still ongoing. And essentially, the Department of Environment wanted to appeal to dismiss these allegations against them, but in fact, that's not the case. We're far too far down the line, and the minister is now bound. Has a duty to act to fix this problem, including something that I'll now go on to, which is about the South African National Ambient Air Quality Standards. So before I change slides, several years ago, I was asked to serve on a committee for the Department of Environment, particularly to look at minimum emission standards, as well as the National Ambient Air Quality Standards. And when we first met, I was very disappointed because this had shortly followed my work with WHO to revise the 2021 air quality guidelines. So I was excited to bring this information into the South African space. But at the time we met, we were told we would only be discussing minimum emission standards and we were not going to be discussing the ambient standards. And I was really upset. But I was told that there was not sufficient evidence for South Africa at that time to really put forward the push for a change in our standards, which is interesting because we'd done these cross-sectional studies. So what did we do? We worked with the Clean Air Fund to launch one of the first studies in South Africa that used observed retrospective data in a much larger longitudinal assessment of health impacts, both mortality and morbidity, in these three pollution priority areas of South Africa. And we launched this in March of this year. And there's a great picture. Myself, our National Air Quality Officer, two of my colleagues, Mr. Vamile Sinene from the Clean Air Fund and Ms. Bono Nembakula from the Department of Health, Air Quality, Environmental Health. So we found using South African data, there was no way around this. There was no model data, no satellite data. We used the ground-based data of the government. We used the death certificate data, and we used district health information system data. And we were able to then look at what are the cardiovascular and respiratory risks, both in terms of death. And then we also looked at that's the left-hand side, the right-hand side, we were looking at pneumonia in children under 5. You can see that the data is messy. It's not easy data to work with. Many of those are crossing the value of 1, which means they are not statistically significant. But we did find evidence that there were impacts on health. Very briefly, what were they? Respiratory mortality remains a major mortality burden in the priority areas. Some details there, the slides can be shared. Cardiovascular mortality remains a major mortality burden in our priority areas. The same for pneumonia in children under 5 and TB mortality, where TB is exacerbated by air pollution exposure. So what did this evidence lead to? Remember, we had built trust with our government officials. They wanted us to use real data, and this led to this report that we launched, as well as a policy brief. And I'm not allowed to have shown the slide, but I am anyway. I'm delighted to share that all of this evidence has now been put together to inform a committee meeting to revise the South African National Ambient Air Quality Standards. Now, what makes this different, and I'll conclude on this, is that that work that we did in the end relied on a quasi-DLNM case crossover analysis, far more sophisticated than any of the cross-sectional work that we had done in the past. But we used locally collected data that people trust, even though it was messy. And we've come to the point now we will be able to revise our national standards in a space where our government officials feel that it is safe, that they know that the data they can rely on, and hopefully we'll get a great outcome with some much more stringent air quality standards for our country. Thanks very much, Victor. Back to you.
Thank you, Karadi. So I think in the course of your presentation, you have highlighted a recurring question in the course of this series, actually, which is in many cases, participants felt, the government is not listening to the evidence that we are generating. Maybe some of the researchers, I think you have given a good example. And in many ways, South Africa leads by example across the continent. There are countries who don't even have standards, but yeah, I'll come back with a question on that. So I think at this point, I will invite, and colleagues, please also post your questions for Karadi in the Q&A. So I will move on to Dr. Rebecca Natanda from the Makerere Lang Institute to tell us a bit about her work. Rebecca, floor is yours.
Thank you, Victor. Let me see if I can share my slides. Kindly confirm if you can't see them.
Yeah, they're coming up. Yes, we can see them. Just
a second. Sorry, let me just do this once more.
Okay.
Yeah. Okay, I hope this is fine now.
Yes, all good.
Yes, so yeah, good afternoon, good evening, or good morning. Rebecca Natanda is my name. I'm a pediatrician and senior research scientist with Makerere University Lang Institute. And today I'm going to be shifting to more practical issues in the field, sharing some of the experiences I've had in some of the air pollution studies that I've done, and focusing on the challenges. So we're talking about air pollution and health. And as researchers, we really want to be interested in getting high quality data so that we are able to generate high quality evidence, which you can tell the policymakers, but also very important, especially to me, who is also, I do a lot of advocacy on air pollution, to tell the general population based on high quality data. And for us to be able to do that, what you plan and how you implement it in the field is extremely important. So I'm just going to share some of the challenges regarding the designing of epidemiological studies on air pollution, air quality monitoring, as well as exposure assessment. So as a pediatrician, I'm really interested in air pollution because it affects our health. And as you may see, it affects almost all body systems. So the question to somebody probably who is not in the air pollution space, or a common person or a policymaker, how does it happen? Why is it that when I inhale particles, which are invisible most times, I can actually have heart problems, I can have brain problems. The lungs, it's kind of easy because you are breathing in, but for some of the other systems, it becomes difficult to explain to the general community, to the policymakers. And so we need to kind of generate evidence to try and improve the understanding on how air pollution actually affects our body systems. And that calls for really trying to understand some of the things that I'm going to mention before I go to the examples. So when you talk about air pollution, there are different particles, but they are broadly categorized into two. There are particles that we call the inhalable particles. These, you breathe them in the nose and the mouth. But just to clarify that not all the air pollutants go down into the lungs and into the bloodstream. So that brings us to the other terminology, which we call the respirable particles. So this is a fraction of those particles that you inhale, but they can penetrate deep into the lungs through the gaseous exchange membrane, where we exchange oxygen is taken into the bloodstream to the rest of the body. And so those particles move along. And some of the examples are what we call the ultrafine particles. So when you're designing a study and you're looking, for example, at the heart effects, probably the kind of measurements you want to do is the ultrafine particles. You should be able to generate evidence because it's beyond the lungs, it's beyond the upper airway. So understanding what you're trying to measure and therefore how to measure it is going to be very important in trying to generate high quality evidence. And this slide is trying to demonstrate the size of the particle. So what I'm trying to say that the size of the particle matters in terms of the health effects, but it also matters in what kind of measurements you're going to use to be able to generate evidence to confidently say, for example, that the prenatal effects or the low birth weight that I'm seeing was as a result of, the air exposure, and I was able to measure, the air pollution. So generally, when you have particles that are more than 20 micrometers in diameter, these ones usually, they're efficiently removed by the nose. So the nose does the first work. Probably you will sneeze and that's the end of it. And then as you go down, those that are usually 10 to 20 micrometers are likely to stay in the throat. And maybe you might be able to clear them if you're an adult and, and maybe clear them. But the smaller the particle, the more deeper it goes, to the extent that by the time we are looking at particles that are less than 0.5 micrometers, these are the ones that are very problematic because they go beyond the lungs and penetrate into the circulatory system. And those are really responsible for causing the different body system problems that I described a little earlier. And therefore, it's important to put this into context. Now, when it comes to exposure assessment, like I mentioned, are you measuring inhalable particles? Are you measuring the respiratory particles? But also, sometimes you have challenges explaining the dose. How do I determine the dose of exposure? Is it from the gadget? Is it from the story? Is it from the observation? If you look at those two photographs, you probably could quickly conclude that the child and probably the father are exposed to very high levels. But we don't know whether that was for 2 minutes or 3 minutes. And then when you come down to the lady who is frying probably some donuts, there doesn't seem to be any smoke coming through, but certainly we know that there is air pollution because she's using wood. But from just observing, probably you would be wrong to think that there is higher exposure in the first instance compared to the second instance. So that's when beyond observations, beyond questioning, the air quality measurements become very important. Looking at the duration of exposure, was it short or long? The frequency. So in the studies that I'll describe later, there are sometimes when we did air pollution exposure, we measured for 24 hours, whereas in some instances we measured for 7 days. Sometimes you'll find studies where they are measured for 3 days. How long should you measure? And the reason why I'm saying this, because especially for household air pollution, for some communities, the behavior around cooking varies across the days. Probably even the type of fuel that is used on different days, depending on who is cooking. So you might find that actually the levels of air pollutants vary across the days. The people who are exposed across the week may be different. Maybe during the week, it's the person who stays at home to help, but maybe on the weekend, it's the mother and the children because now they are at home. So again, when you're trying to look at the health effects, you need to think through some of these issues so that when you're concluding, you're actually concluding from well, articulated evidence. And I'm going to share examples, one from household air pollution, another from ambient air pollution. So in this Impala study, our aim was to describe the maternal and household factors associated with lung function in young infants. It was a birth cohort study. It was in rural Uganda. Those of you who have a sense of how rural Africa looks like, we'll see some pictures later, but it was really in rural, very rural Uganda. And we enrolled 567 pregnant women. It was regardless of the gestational age. Again, this is very important. Like my colleague who first presented mentioned, what is the best window where there is high susceptibility? Do you want the first trimester? Do you want the second trimester? Is it the third trimester? But it also depends on what outcome you're measuring. Maybe if it's birth weight, it's a different trimester you're going to look at. So it's important to decide when you want to do the measurements. But this was now in the field. In the first photograph, we are measuring personal carbon monoxide exposure. Let me see if I can have a pointer. So this is called Alaska. So we asked the pregnant women to wear it. So this woman was in her kitchen. She was going, I think, to prepare something to eat. So they had to wear it around every time to the extent possible for a period of 7 days. And then in the same study, we had the Dialos. So this is an instrument that measures PM 2.5. So this was put in somebody's kitchens. This is wood, which they use for cooking. So the best area where we could mount it was on top of the wood. For those 24 hours when we had our gadget there, she couldn't use her wood to cook because our gadget was there. Now for this lady, this is another kitchen. It was mounted up on top of the rack where she was putting her wood. So different ways of measurement, different environments, and it takes you to think about what measurements am I looking at? How am I going to interpret them? So when we measured the lung function, rather the air pollution, both the carbon monoxide and PM2, what we wanted was to look at the lung function. So we did measurement of the lung function in the babies, and we wanted to see if there was an association between the air pollution exposure. So the exposure was to the pregnant woman. That's why we did personal carbon monoxide monitoring, but also we measured household air quality in the households of those pregnant women. Now, looking at some of the challenges, besides the actual conducting of the measurements, you want to think through, or maybe a question to the team just for you to think through, what are some of the possible challenges you think when people are doing air quality monitoring in rural areas could be experiencing. What I mentioned was just really a tip of the iceberg, but there is much more. So you could think about what challenges are to happen during the process of data collection, but also when it comes to data interpretation. And I'm going to highlight some of them. So in this case, where we're using the LASCAN, so the instrument looks like this. So the women were supposed to carry it around 7 days, 24/7, like we usually say. So we had to design something like a bag, small bag, so that they could wear it. But we also had to make sure that the area which is supposed to trap the pollutants remains open so that the measurements could go on. So you find yourself that you need to find a way which is feasible within the community to be able to do air quality monitoring without making it so cumbersome for the participants. So there was an ease of carrying the monitor everywhere. The social challenges. So one of the things we experienced when we gave this small LASCA to the women, the pregnant women, because they had to take it everywhere, including the bedroom, the men were up in arms saying that we are monitoring the bedroom activities, something we had not anticipated. So these are practical things you might find. The same thing happened when we are monitoring using the dialogues. It kind of makes a noise, a slow noise, and they were unhappy that disturbing their sleep. So whereas we are doing the measurements, but there are social issues which you might anticipate or encounter and deal with as you do the air quality monitoring, especially in the households. But also the accuracy of the data. Like I mentioned earlier, if I go back to this picture, for example, we are looking at exposure of a pregnant woman. There is no one here. Probably she wasn't around for the whole day that we are measuring. Can we conclude that what we measured here that's what she was exposed to, and we measured it for 1 day? The good news is that because behavior doesn't change a lot, probably what we measured here could be the same every other single day. And so we could make conclusions that probably that's the kind of air pollution she's exposed to. But also remember, this is in the kitchen. She doesn't sit here the whole day. So again, interpreting what you get within the 24 hours becomes important. And that's when those models really become very important. I think the other challenge is, again, observing the SOPs. We tell them what to do, how to do it, but we wouldn't know whether sometimes, they take off the LASCA and put it elsewhere, or they don't want to go it with the market or to charge, again, for the social challenge that I mentioned. So sometimes if you find that it was low level, you're wondering whether it was really purely low level or it was because somebody wasn't really wearing the LASCA to the environments where she was moving. So I've gone through these questions, but again, who is exposed when you're doing the monitoring? For how long are they exposed? The dose, what you read, is it what is representative of exposure actually? Like I mentioned, comfort from the household members, but also what we experienced was the theft of the gadgets and the battery life. So some of them you may measure, you may think in advance that, oh, this battery takes about 36 hours. But then when it's put in an environment where there is a lot of air pollution, it runs out very quickly. And so you may find you have to mitigate these issues or anticipate and plan for them in advance. So in this particular study, we had batteries that were strapped together with an air quality monitor, and the people wanted to steal the batteries. So we found our gadgets were stolen. Some of them were disorganized. The loss of the gadget wasn't very important, but you lose the very important data that you're actually looking for. Those are challenges we find in the field. So the other thing that I want to talk about is the choice of the study site. In this particular study, we wanted to look at the association between air pollution and lung function in the infants. It was a rural, cohort. And what we found that almost everybody was exposed to high levels of air pollution. So it was difficult to make conclusion because the comparator, we didn't have enough numbers. Again, looking at the positioning of the monitors, is it in the house? Is it in the kitchen? Is it outside? To what extent can I really describe the air pollution exposures? Now I'm going to turn to the second example. So this was a study where we're looking at school children, looking at the air pollution exposures in different environments. It happened across 6 cities in sub-Saharan Africa. So these adolescents were 12 to 16 years. We had 330 of them. They had asthma. They were in urban schools, and we did air quality monitoring while at home, in school, and while they were in commute to and from school for a period of 4 days. We used a small gadget. This is the monitor that we used. Thankfully, it is light. But we also managed to get these backpacks where we put the battery, so they could use the same bag to do the monitoring for ourselves, but also put their books and maybe their lunch and everything. So it became easy because they could relate with the idea of carrying the bag, and it was a beautiful bag. But there were also some challenges. So they carried this bag for 4 days. They were expected to have this bag near them while in class, to walk with it to and from school, to be with it most of the time when they're in their home, maybe when they are going to the well, when they are going to the shop, when they are going to the market. So you can imagine to what extent some of these things may be cumbersome, but also the likelihood that you may not end up with accurate data. So some of the challenges which can happen when you're doing exposure monitoring in such instances, the load to the child, extra load. Thankfully, this was very light, but some gadgets are really heavy, and when you're putting an extra load for the child, it may be really challenging. And then children want to be free if it's time for play to go out in the field and play, but they had to carry the bag everywhere. And sometimes we had instances where they just decided to leave it at home for the 4 days, so we had missing data as well. Some of the things we tried to do to mitigate the problems, we sent reminders every morning so that they could go with their bag at school. But thankfully, we also had the global positioning system, the GPS data logger in the bag, so we could know where they were at what point in time. So that really helped a lot. And that's how we got to know that for some days, people did not actually carry that. Back to the school, but we also gave them a diary question so that it helps you to design the study to measure the outcomes you want. The data collection methods need to be defined, and the equipment that is needed needs to be well defined. But also rigorous follow-up is very important. But what we learned is that you have to keep learning and responding without compromising the science. And this is photographed. That's when we had to call a community meeting to explain the LASCA issues as well as the DILOS issues, how we're doing the air quality monitoring. Thank you, Victor, and back to you.
Thank you, Rebecca. I think you've really gone through some of the practical sort of issues that we face in the course of designing the studies. As a man, I identify with the social aspects of one of the studies you mentioned, very valid concern there. So I think we have about 20 minutes to go through our Q&A session. I'll just ask our speakers to have their cameras on. I had actually a follow-up question for Sarah, but I'm happy that it has come up in the Q&A. So the person did not leave their name, but they are asking, Dr. Kali, he just wants to know your opinion on the main limiting, sorry, not that one. Yes, your opinion on the limiting factors of continuous collection of longitudinal data for the graphs cohort. So I'll just contextualize this. In the scoping review that we did for East Africa, we found lots of cross-sectional studies, very few cohort and longitudinal studies. One of the challenges I've had for some of the groups trying to do longitudinal studies is, so you have a cohort, but then following them through, you tend to lose people as you go. Do you have the same kind of concern with sort of getting longitudinal data in your context, Sarah?
Yeah, absolutely. So that's a very interesting question for longitudinal design. So I would say, yeah, the key thing is to establish that rapport with the study communities, which we've done in Kintampo. We have a long history of community engaged research. So we are able to reach out to them, to community leaders right from the start of the study to understand what factors would impact recruitment and retention. And then in the course of the study, we do engage participants from time to time. But that being said, long-term follow-up is a challenge. Attrition is a big issue. Yeah, but working together with community leaders, with participants to try to increase or maintain their interest, and that helps a lot. So from time to time, it's important to get in touch with participants, disseminate your results in an easy to understand language, so they feel a part of the whole project.
Yeah, is your data publicly available for the graphs study?
So at the moment, no, we are working to make it publicly available because I think now that's a requirement by most funders. Yeah, so we're developing the database and then developing the modalities, the SOPs to make that publicly available.
Thanks for that. So that was a question from Abba. He was just wondering whether the data is available. So I'll move on swiftly to Karadi. We have a question here, which, as I said, this has been a recurring sort of theme in terms of a lot of participants wondering how do we even get to influence policy. So the question is, let me just see. How would you advise other countries to sort of, oh yeah, here it is. How are you working with policymakers to make sure that this evidence is translated into policy? I think this applies to all our presenters. So maybe Karadi, you can go first, then Rebecca, then Sarah.
Sure. So it's a tough question, and it's not an easy answer. And I don't think there's a one-size-fits-all approach for everybody. In my experience, it's been about relationships. It's about offering to support and help without pay or remuneration when the government has put out a document for public comment, put forward public comment, put forward your evidence, take the time to do it, make relationships with the people in those government spaces, and then offer to support them. The way I think we cracked it originally was if you go and have a look at so the government has a performance review plan, right? And they have to tackle tasks. And so I would go and look at what the tasks are that they're trying to do and pick one or two and say, well, I can help you do these tasks. And then I integrated it into either my existing projects or I'd get students to support, and I'd provide the human power to get some of that stuff done because they can't do all of it on their own, and yet they measured against it. And so we did that, and then really nurtured the relationship and trust. And ultimately that has evolved. It's taken 20, maybe not quite 20 years, 10 years. It's evolved into an MOU. So there is now an MOU between my research program at the MRC and the Department of Environment. And so this gives us a segue into making sure that we align with what they need, but they also take on board what we produce. So I think it does come down to relationships and trust and putting yourself out there. And unfortunately, that does mean time and resources where you can to support them.
Yeah, thanks, Rebecca.
Yeah, thanks, Victor. One of the things I think which we need to think about as scientists is the fact that many people, including policymakers, may not readily understand how air pollution affects health. Whereas it's easy for us to have the numbers and the odds ratios, they struggle with the fact that if I'm exposed to air pollution, which they don't see most of the time because it's invisible for most people, how does it affect health? I think that's the first point. And one of the things I've experienced is when we are trying interventions, whether it's an awareness intervention, whether it's a research intervention, we need to work with them right from the start so that they understand what we do, why we're doing it, so that they can even speak to the results. That's extremely important. So we need to bring them on our side, not to act as science, we are on this side and they're the other side. Then the other issue which policymakers love, and I think this is global, they always ask, what is the return on investment? If I put this intervention, how much does it cost me? How much do I gain? They think in terms of money because of the limited resources. They want to put money, like we say, where they see the results. So it becomes difficult for them to visualize, to even imagine any return on investments on the interventions that we propose. And so we must step out beyond the science that we are producing. We need to start showing the cost of air pollution, of doing nothing, but also what it costs to do some of these things and what the return on investment so that they can see how it works as policymakers. Then they can prioritize it. Thank you.
Well put, Sarah.
Yeah, so thank you for that. I think Rebecca does raise two very important points, which I identify with. First is to engage policymakers from the outset. And that's what we try to do here at Kintampo in Ghana. And we are at a unique position because our research institute is part of the Ghana Health Service. So the government agency that's responsible for implementing healthcare delivery. And so our research fits directly into the Ghana Health Services policy. So we try to engage them right from the beginning because they do not understand the things that we so easily take for granted. So that's a key thing. When we do community engagement at the start of the study, we have a national level one as well, where we engage the health authorities on that. So the second point is about economic cost, right? So I'll take it further to say that for the health studies that we do, we should be thinking about doing an economic evaluation. So if you show politicians or policymakers, how much money you can save by implementing clean air policies or clean cooking policies, how much or how many deaths or diseases that you would have otherwise spent money on. I think that will ring home. Yeah.
Yeah, well put. So I think also the other thing, just to add to your voices, obviously reducing costs and optimizing costs for government is essential, but also integrating with other things. So if you reduce air pollutants, you have advantages to climate, you have advantages to all these other sectors, because then that optimizes the cost as well. So not looking at things in isolation as well. In as much as this is an air pollution and health, we also need to look at things in totality when it comes to reducing some of these costs. So there's one question here that I'll pose to all of you, a very interesting one. It kind of summarizes this entire series. So I'll put you guys on the spot, but feel free to pull in the direction of your respective expertise. So Mujtaba is asking, he was actually directing this question to you, Rebecca. So nice presentation, Rebecca. But I'm posing this to all of you. What are the biggest data limitations for air pollution and health evidence in Africa, in your opinion? Is it the monitoring density? So we don't have enough monitors. Is it that we don't have emission inventories? Is it that the demographic data is not sufficient? And what should be prioritized? So I know you're not experts in some of these areas, but you can also say we don't have health data and we should prioritize that. But how would you respond to this? We start with you, Rebecca.
Yes, thank you. Very important question. So, number one, it depends on where we are. Whereas we are all in Africa, probably some countries may be ahead, for example, in terms of air monitors, compared to others. Or even within the same country, you may find probably the urban people have more air quality monitoring compared to the rural people. And yet, air does not know boundaries. So, it will affect you wherever you are. So that context is very important. But I think for me, again, I'm going to go back to being a health practitioner. Whereas we have some health data which we can use, in most of our systems, the accuracy of the health data becomes a challenge because it starts with if you wanted symptoms, how many, for example, health systems are able to put those symptoms that we want to look at if I wanted an outcome on symptoms. If the diagnosis, I'll talk about respiratory problems. We know that most of the respiratory problems like asthma and COPD are very much underdiagnosed. So when I go to the health registry, even if I have very good air quality data from the monitors, can I use that to make conclusions? So for me, I think health data remains a challenge. But also, I think my colleague mentioned it earlier, we need to move a little further into doing mechanistic studies so that we can bring out the biology or the problems that really are on the human being. But also when we have the interventions to show that this is how the interventions, for example, repairs the body, for example, or prevents the body damage, something like that. So those, I think, are challenges that I could mention, but again, the context is very key. Thank you.
Thanks. Karadi, would you like to contextualize this for South Africa as well?
It's hard. I'm very optimistic about data. So that was the question, right? We were talking about data. I'm very optimistic about data. Data exist in places that sometimes we may find challenging to access, and they may also be in form that is not readily implementable into any kind of modeling. That means that we have to find resources to tap into to activate those data for meaningful use. There's definitely scope for doing so. And so something that we've been working on recently is visualizing data that we have in South Africa. So we have, obviously, we've got some air pollution monitoring stations around the country in a network. They're clustered in places and there's none in others. And we've got district health information system data from primary healthcare facilities. And what I've been doing is taking all of this data and visualizing it on the South African Climate and Health Surveillance Platform. It's a website, climatehealthsurveillance.org, just to show our decision makers and our policymakers, government officials, look at your data. This is what your data looks like. Let's overlay it. Let's overlay air pollution and health data, or let's overlay floods and health data. And it's not about DLNM. We're not there yet, right? We're obviously going to work towards understanding the relationships between the two so that we can project and provide information for preparedness. But for now, it's just look at the great data that we have. And sometimes it takes an enormous effort to get those data, to get 15 years of hospital data from one hospital where the books are down in the basements of the hospital, under dust, and then scanning it and then coming back and then manually entering each line with handwriting you can't understand. It's an enormous effort, but look at the value of that when you see it on a digital platform. So I think we have data. It's tricky to get hold of. Sometimes it's difficult, but we should use what we've got. And we should use showing what we've got to lobby for why we need more.
Yeah, thanks. Sarah?
Oh, so I think Hardy and Rebecca have so eloquently answered the question. The little I'll have to add, I mean, what they talked about apply to Ghana as well, to the challenges we are facing as well. What I'd like to add is that so in Kintampo now we are faced with a situation where we have some ground level monitors that was part of a funded research. That research is ending, and now we have to make a decision as to whether to keep the fleet or not, because keeping it has cost implications, and we don't have any funding for that. But we would very much like to continue keeping this and continue monitoring air quality and relating these beautiful data to health outcomes. But these are the challenges, lack of funding limits the amount of work that we can do on the continent.
Yeah. So I think we have about 5 minutes. I just take not really a question, but rather an appreciation from Daniel Odo. He says, it's great to see some of the important moves or projects and projects that we've seen in the course of this presentation from each of you. I think he echoes the sentiments of most of the participants and us as HA as well. It's been a pleasure having you. So as your last 1 minute sort of quick remarks, and he poses a question, what do you think are the next steps for us as a continent in this sort of journey, air pollution and health study, research journey? So I will go in the order that you did your presentations, starting with Sarah, then Karadi, then Rebecca.
All right, so I think as I indicated in my presentation, if there are existing cohorts, existing surveys within the continent, I think we can incorporate air quality monitoring into these existing studies and then take it from there. I think we should also be thinking systems epidemiology and add in biomarkers so we can identify causal pathways, we can identify susceptible groups, and then we can identify targets for interventions.
That's a great comment. Thank you so much. I'd like to add to that by saying that I'm particularly excited about exposomics. So that links with the biomarker work that you were talking about. We are hoping to launch the Africa chapter of the Global Exposome Forum in South Africa in December of this year. I spent time 2 weeks ago in Brussels working on the exposome ethics declaration, because obviously ethics is a big thing. Exposome is understanding all of the exposures that a person is exposed to throughout the life course, from conception all the way through. And I think we've got great potential here in Africa to apply this framework. It's going to be expensive, but it's going to be as much of a breakthrough as it was mapping the genome. So yeah, watch this space. Please get involved. Global Environment Forum, African chapter. There will definitely be a big focus on air pollution.
Yeah, thanks, Victor. I think, 2 parting remarks. Number one, let's involve the citizens in the science that we do. We expect them to take up these interventions, and yet they haven't been part of the journey. It's going to be extremely difficult. And the second thing, for air quality interventions, whether it's policy, whether it's health education, whether it's technology, I strongly recommend right from the start putting in place in mechanisms of monitoring, evaluating impact, and learning along the way so that we can scale up, we can replicate. We need that evidence, because most times the implementation is not followed by, a good framework of monitoring the impact. Thank you.
Thank you so much. And with that, I think I would like, on behalf of HEI and our participants, to thank all of you, the 3 of you, for making time to be with us today and for your insightful comments and additions to this conversation. So Colleagues, I think we come to the end of this training series. Well, this is the last of the series, but definitely not the end of the conversation. We hope to see you in Pretoria and continue this conversation. In the meantime, my colleague will post a survey for you to fill and let us know how you have enjoyed this series. Is there any other topic you'd like to see or hear from us? I'm taken back to a time when I was doing my graduate school and my first lecture on atmospheric chemistry. My lecturer was like, the atmosphere is complex. And then proceeded to show us many chemical reactions. So we have tried to tackle a rather complex issue in the last, couple of sessions, including today. We've tried to keep it broad and as meaningful to all of you as possible. And we look forward to maybe future engagements on the same. Lastly, I'd like to thank my colleagues from HEI, Pallavi Pant, who's hosting us today and is in the background posting all the links and questions. Our colleagues in the communication department who've set up this webinar for us, and everyone else who's put this together. So an appreciation to all of them. So thank you all. I think we have representation from across the continent, from Mozambique, South Africa, Uganda. I've seen Nigeria, Ghana in your inputs in the chat. And beyond USA, I think I've seen India and many other places. So we appreciate you. We appreciate the time you've taken to be with us. As usual, everything will be put together and uploaded on the webinar website, and the link has been shared with you as well. So without further ado, I wish you all a good evening, good afternoon, good morning, wherever you are. And thank you once more.